Hi, I'm Dr. Jack West, and I'm a thoracic medical oncologist at the City of Hope Comprehensive Cancer Center in the Los Angeles area.
And I'm Dr. Julia Rotow. I'm also a thoracic medical oncologist at the Dana-Farber Cancer Institute in Boston, Massachusetts.
We're here at ASCO 2023 in Chicago, where we've been seeing some really blockbuster presentations in thoracic oncology, and many of these have brought up some important questions about the clinical implications that we need to discuss a little further. At ASCO, as well as in the couple or 3 months preceding ASCO, we've gotten more and more data on perioperative approaches. Of course, over the last couple of years, we've had some new options of postoperative immunotherapy for a year, say after chemotherapy or possibly after chemotherapy. We have also had very influential data, the Checkmate 816 trial that gave 3 cycles of chemo with nivolumab versus chemo alone to patients with stage 1B to 3A disease, but largely nearly 2/3 with 3A disease, that showed a very clear improvement in the pathologic complete response rate or PAT-CR rate with Nivo added to chemo, and also a significant, highly significant improvement in event-free survival and a strong trend toward improved overall survival. This is FDA approved and has been increasingly adopted, I would say, maybe with some variability by geography and center, but really a good amount of enthusiasm. Now we have a bunch of trials that give chemo with immunotherapy. We've got the Adjuvant trial, and that was with durvalumab. We have NeoTorch with chemo and toripalimab. And we, at ASCO 2023, we had a highly prominent presentation of Keynote 671, 4 cycles of chemo with pembrolizumab versus chemo and placebo. And there's that, and then there's the built-in postoperative component of a year of immunotherapy as well. In all of these trials, the data for Keynote 671 looked quite good. Of course, the other trials also were significant, but you need to weigh that against, I would say the comparator now is not nothing or chemo alone anymore. It's really against what is the best current standard of care. And the real question is, if we were happy to do chemoimmunotherapy neoadjuvant with chemo-nivo, do we need to add the year of immunotherapy? Because it certainly adds some cost, it adds some risk of toxicity, and it adds a year of a patient coming into the clinic and getting IV infusions all of this time to get a treatment that the patient has already had for 4 cycles in most of these trials. And if your cancer is resistant, is there going to be an incremental benefit to giving more of it? What are your thoughts about the risk and benefit and going to a patient in your own clinic? How are you going to counsel your patients? And will anything change after the presentation of all these data and how you approach preoperatively?
Yeah, I agree. In some sense, it's an embarrassment of riches, right?
Yes.
We have so many positive studies looking at perioperative immunotherapy for our patients, and they all show improved outcomes. But of course, they all compare to the old control arm of chemotherapy alone in some form, and this is no longer a useful control in this space. The open question is, do you need neoadjuvant, do you need adjuvant, do you need both? My high-level takeaway from all this data is that the neoadjuvant component appears to be important. I think the overall trend, comparing across studies, of course, outcomes seem to be better with the neoadjuvant component. You also get the advantage of potential downstaging, potential greater ease of surgical resection. We know they have lower morbidity resection, shorter surgeries. We can comment on that. You get also your pathologic response data.
So you get the feedback.
Exactly.
And the deliverability is also a big issue, that you can much more reliably deliver your intended treatment by doing neoadjuvant and followed by surgery.
Exactly.
We know there's major drop-off if patients have surgery and in the recovery room they hear you got it all, and then then they need to come back and maybe get chemo and immunotherapy for a year. They'd ask, what for? I can't see anything.
Exactly. I think there's a lot of advantages to that neoadjuvant component. And I think all of us, or many of us now, have integrated this into our routine practice. Now, the question is, do you need the adjuvant element or not?
On top.
On top. And that is challenging because no trial has compared adjuvant to non-adjuvant. I think we all advocate for the need for this trial to answer this in a more randomized perspective fashion. But of course, that doesn't help our clinic practice tomorrow when we see a patient.
Or for the next 4 years.
Or for the next 4 years, exactly. So there's going to be the open question, who really needs this? And in some sense, we may be guided by the path response during the surgery itself. I think there may be those who claim if you have a path CR, do you really need additional therapy? We don't know the answer, but it's tempting to say we know the outcomes and event-free survival are extremely good with a path CR.
Which is only 20-25% of patients, so it's not most.
It's not most, but it's better than the 2% or so with chemotherapy alone. So that's real progress, and it's nice to have that readout. But that 80% without a path CR, the question is what to do. And I suspect there will be variation from provider to provider and from patient to patient, depending on tolerability to prior therapy, patients' wishes around the goals of care, patients' risk for autoimmune toxicities. Maybe there's a patient with an underlying autoimmune disease who's gotten their neoadjuvant therapy and done well. You don't want to risk that ongoing risk of exposure. But perhaps a patient with no risk factors who desires very aggressive treatment might be interested in more treatment. A subgroup that I was interested in Keynote 671 was the PD-L1 subgroups. And these did trend the way you expect with better responses in PD-L1 high, but there were also good outcomes and benefit to immunotherapy with the perioperative strategy in PD-L1 negative patients.
So that didn't really exclude anybody.
Didn't exclude anybody. Checkmate 816, everyone benefited, but the benefit was less with those PD-L1 negative patients.
True.
Absent further data to guide me or any prospective data here, comparing these strategies, I might lean towards a longer course of immunotherapy in that population in hopes of triggering a response. But I suspect there will be variation from clinician to clinician in that space.
Yeah, this is a setting where I feel like I have equipoise. I really feel that the incremental benefit is pretty small,
I agree.
And frankly, somewhat dubious. On the other hand, you're in a situation where if you know that 3 out of 4 patients will experience a relapse and less than amazing outcomes, it's hard to leave something that's FDA approved and studied and a well-sanctioned option on the table if this patient may have relapse later. In the end, I feel like I'd like to offer this, discuss it with all of my patients. And I think it's a great place for shared decision making, because if a patient hears about that and decides, I'm not interested, I'll sleep fine with that. I think that's a very sensible approach, but I don't want to make it unilaterally. And other patients may say, I want every opportunity. And if it comes back, at least I'll know I did everything we could.
Exactly. And I agree with your statement about equipoise. I truly think that this is present here in this situation, and there's room for discussion in both directions with patients. Now, one caveat I'd like to add to all of this data is that it should not apply to patients with some of our classic non-smoking associated driver mutations. And this is another piece to the neoadjuvant data I think is worth commenting on, just the need to get appropriate testing before initiation of therapy, and the pitfalls of starting this kind of treatment without knowing full biomarker testing. And I think that's something we have to watch for in our clinical practice as well.
And perhaps especially if we're talking about doing a year of postoperative and someone has an ALK rearrangement or an EGFR mutation and you didn't know it. And that is a group where we're definitely worried about a rapid transition and potentially prohibitive, even life-threatening toxicities from not planning in advance for this, because this is something you don't want to give concurrently or one right on top of. You don't want to give immunotherapy and then transition right to targeted therapy. It's dangerous.
Exactly. You don't want to, the stakes were already high with neoadjuvant alone, but at least you had that gap of the pre-surgical period, surgical recovery, and then initiation of adjuvant therapy if needed or at relapse. But with a post-op long adjuvant period, that stakes are elevated because the immunotherapy exposure continues. So something to be mindful of.
And we have a general sense that many, but not all of the targets that we're talking about are associated with low benefit from immunotherapy, but it's not that well studied. I think this is another place for individualized discussion of the pros and cons. They were included in the trial, but they probably benefit less.
Exactly. I think with the best established EGFR and ALK probably are not benefiting a lot. And of course, they're actually included in the trial. Many of the neoadjuvant studies do not allow them to enroll if they're known. I think on the other end of that spectrum, KRAS is just fine to treat with immunotherapy.
Sure,
it's an actionable driver. It's not a traditional non-smoking associated driver, and those are just fine.
The studies show that these patients benefit just as much, at least, as the other.
Exactly. So I would never withhold this form of therapy for a KRAS driver mutation. The others, I think, are still in a gray zone, and depending on the patient demographics, history of tobacco use, I may elicit more or less caution in that space.
Well, I think we're going to have a lot to still tease apart, a lot of room for judgment here without a strong sense of the data telling us exactly what to do.
Exactly.
Julia, thanks so much for taking the time. There's a lot of excitement, a lot of interest in these new data, but still a lot of open questions. And I hope we continue to mull over it as we get a little more data and more insight to shape our plans.